Good morning. My name is Richard Smalling. I'm an interventional cardiologist. I do a little LVAD work on my spare time, but I'm a visitor here, basically. Dr. Stravis Dracos has joined me to chair the session. Could we have our panelists introduce themselves as we go down the line?
Arvind Bhimraj from Houston Methodist. I'm one of the advanced heart failure cardiologists.
Khalid Shatila from University of Texas Medical Branch, Heart Failure Cardiology.
Ismael Salas, University of Texas, CV Surgery.
Good morning, Carolyn Rosler, Inova in Northern Virginia.
Good morning, Neil Riel from Columbia and Cornell University.
Hello, Amanda Vest from Cleveland Clinic in Ohio.
Thank you very much. We'll like to have our first speaker come up if you're here. Here we go. This is Dr. Jamie Deneau, who's a critical care nurse and specialist in advanced heart failure space and is at HCA Healthcare. Welcome.
And I'm an advanced practice nurse, not a doctor. I did not sleep at a Holiday Inn Express last night either, so. But I was asked to talk about Code Blue on MCS today, which for me is actually a fun topic. I am that person that will walk around a hospital and say, it would be nothing like a really good code today. So we're going to talk about that. And then we also have to keep the caveat in mind that when you're on MCS, nothing is normal. And a code on MCS goes right along with the fact that nothing is quite normal. So first things first. First thing we have to do is always assess our patient. Because MCS is not normal, our patient presentation and what is perceived as a code also might not be normal. It wouldn't be unusual to see what could be a lethal arrhythmia on a monitor, and your patient is sitting up in the chair eating breakfast and looking at you like, why are you coming in with 46 of your closest friends and all of this extra equipment? I just want to finish my scrambled eggs. So always look at that patient and what is their level of consciousness. You can try to check a pulse. Sometimes it works, sometimes it doesn't, right? MCS isn't normal, and so our patient isn't going to present normal either. Blood pressure is great if you have a way to get that and a way to get that quickly as well. If your patient's intubated and you have an ICU that routinely monitors end-tidal CO2, it's going to be a good idea to look at that for a sign of perfusion, but these things aren't always necessary, and so we have to go back to just the basics of assessing cardiac output in our patients. And then part of our assessment always has to be the device. First of all, know what device your patient is on, obviously key to know what's going to happen next, and is the device properly functioning? Is there flow through the device? Are there alarms going off, and what are we going to do next? I'm a big proponent that if you're walking into a code situation on one of these patients on any MCS device, there needs to be a person or a team dedicated to the patient, and then a person or a team dedicated to the device. You can't have one person trying to manage both of those things at the same time. It doesn't work. And so we're going to have one team looking at the patient, deciding if CPR is indicated. We'll run through some of those indications here in a second. And then what are we going to use out of our typical ACLS algorithms? Or what are we just going to try to figure out? We've heard a lot over the last day and a half, that a lot of what we're doing isn't really backed by great solid evidence. And so it's, what do we know to do? What do we think will work? What makes good logical sense in a patient who has circulation that is not normal right now? And then really looking at what is causing the problem, a differential diagnosis for the patient and actually a differential diagnosis for the device as well. When we're looking at the device, first thing, does the pump work? That really is a big deciding factor on which way we go next. Are the cannulas still in place? Another big decision on how we're going to move forward next. And is there air in the circuit, or there clots? Are those the culprits for the problem that is happening? So we do have patients on balloon pumps, and we have patients on balloon pumps that code. And so if that happens, you want to make sure you're changing your pressure mode right away, changing your mode to pressure instead of EKG or anything else. Put them back to a 1-to-1 if they weren't already there. And max augmentation if there are still nurses that know how to do that. I'm an old nurse, so I can say that. And then as far as ACLS goes, we don't have any deviations. CPR can be indicated for these patients if necessary, and we're just going to follow ACLS. On Impella, again, we're looking at the device first, or I shouldn't say first, but simultaneously to the patient. We need to drop the P level down to P2 if the patient is in a place where we're going to have to start CPR or follow some of our ACLS protocols. It's always right to have an echo in the room or an ultrasound that you can put a probe on that chest and see what's going on actually in the heart. I would say that's never wrong. That person should get a front row escort to the bedside so that we can get that probe on the patient's chest and see what's going on. Hopefully in this situation, it might either be a positioning issue or maybe it's a volume issue, and you can quickly resolve those alarms and get the patient back to whatever their state of well was. But we also have to consider the idea of escalating support on these patients. Is Impella not enough at this point in time? And do we need to consider potentially adding another level of MCS support for this patient? And then there's ECMO. There's not a bit of evidence about what to really do on a patient or with a patient on ECMO that codes. Say a little prayer, walk in the room, and hope you can do your best is really what my biggest solution would be. So again, we're looking at the patient, we're looking at the pump. On VA ECMO, if the pump is on and flowing and you have adequate flow, I would not ever suggest starting CPR on that patient. If the cannulas are laying on the bedside or your pump isn't operating, that's a whole different story. Then we're going to start CPR. If you're on VV ECMO, we always have to remember we don't get direct cardiac output support from VV ECMO, so CPR is most likely indicated for those patients on VV ECMO. I never recommend taking the patient off the vent in a VV ECMO scenario. Leave that alone. Do all your oxygenation and ventilation through your ECMO circuit. And then again, if necessary, you might have to reconfigure that ECMO circuit. We heard this morning VAV, VVA, VVAA, throw in a Protec, throw in something, and see what we can do to try to help that patient. Once you figure out whether or not you're going to do CPR on the patient, you can follow most ACLS algorithms. A lot of people won't go down the epi route with these patients, and that's okay. If your circuit isn't working, you're not cannulated any longer, always appropriate to clamp out that circuit so that you can minimize any trauma from that. And hopefully somebody in the 46 friends you brought to this code with you thought to bring along another primed circuit so that if this is a scenario where we need to change out that circuit quickly, we can do that and nobody's having to run to the 3rd floor when you're on the 5th floor to find where that circuit is at. Durable devices, my first caveat with this, because there is still a lot of controversy, know your facility's protocols. Some facilities will say don't ever do CPR, some will say it's okay sometimes, some will say sure, do CPR. So I don't want to get in trouble. Know your facility's protocols. ACLS does have an algorithm that supports patients with durable devices, and really again it's all about, is your patient awake? What's going on with your patient now, what led up to this situation, and then it's separating the patient from the pump itself. I think any of us that have worked in the durable LVAD space or in the temporary device space, we've all seen those patients that are actually okay, not good, okay, and yet they're in VTAC. And maybe they've been in VTAC for the last 5 days after they went to Sonic and had tater tots at 11 o'clock at night. Not that that's my own personal experience. But we have to look at the patient and are they perfusing well enough that we can have a few minutes to decide what our next step is with these patients. If it's an immediate post-op or fresh post-op patient, we do need to think about the idea, is this a surgical emergency? Do we need to open a chest at the bedside? Do we need to go back to the OR? Is this some type of tamponade situation that we can fix? If this is, a patient months or years out, obviously surgical emergency isn't probably our go-to with that. Neuro events do happen with these patients, and oftentimes I feel like this is something the EMS teams are seeing, is they get there, the pump is alarming, they're focused very much on the alarm coming from the console and not what's going on with the patient, and oftentimes it is a neuro event that leads eventually down the road to some type of cardiac event, so knowing what is happening with your patient neurologically. And then thrombosis, bleeding, of course, is always a problem that we have to think about. If you're taking care of these durable LVAD patients, hopefully somebody that has come with you or you yourself know how to troubleshoot the device itself. What is the alarm going off, if any? Is the driveline connected at the modular cable site, at the controller site? Has the pump completely failed? And there's a lot of controversy about if the pump has failed and you don't know how long the pump has been off, do you really try to restart the pump or not? Again, so that's very facility specific. Has your controller failed? And if your controller has failed, then is there somebody there that can change that controller out quickly? It scares a lot of people if you haven't done it before, but it really is about a 12-second procedure of open a little door, push a button, pull a cord, push a new cord back into a new controller, and you're ready to go. So always be looking at that patient, always looking at perfusion for the patient. Are we perfusing enough? Aren't we? And then what is our differential diagnosis for these patients? And I thank you for letting me go through these quick scenarios and welcome any questions. I maybe should have changed thank you to good luck in these situations. But
Thank you very much. That's a terrific talk. Any questions from the panel?
Jamie, that was a fantastic talk. You went through a lot of really practical tips that I think help demystify really stressful situations. I wondered what sorts of training you do at your institution to make this something that's practiced before you're in this scenario.
I think that's a great question, and I feel like that's probably the key to all of this, is knowing what your roles are. So with my ECMO specialists especially, I'm big on the what-if scenarios. I think sometimes in the ECMO world, if you're the specialist and you're sitting there, some days your days can be fairly boring until they're not. And when they're not at all boring. And so really always walking through what if this happens, what's gonna be your first step? Doing that during some downtime during the day, having routine wet labs to go through those same type scenarios. And then with the VAD coordinators and then the VAD nurses as well on the floors, because the coordinators aren't always there, those same things. All right, you get a call, and I just did this recently with one of my VAD coordinators and said, you walk in the room and the patient's coding, everybody's looking at you, what do you do? And her first response was follow ACLS. And I said, okay, but what is ACLS? And what is ACLS for an LVAD patient? So it's really having those conversations before you're in the heat of the situation, because it's really hard sometimes to keep your cool in those situations if you've never had to go through this before. I'm not a normal person, so like I actually can thrive in a code situation. A spider's on the wall, I will freak out. A patient is coding in front of me, I can be very calm. I'm not a normal person, that's why I like these patients. So really being very mindful and intentional of walking through scenarios before they happen.
Quick question, Jamie. In regards of Impella, I give you a basic scenario. Pump stop. Let's say they rip the connector, pump stop, cardiac arrest. Mm-hmm. The patient you check is in cardiac arrest. How you handle that patient? You have every capability in your institution.
I would say that patient's going to be going either to cath lab or hybrid room or to the OR to get some type of new device placed. If they were that dependent on the Impella beforehand.
In the meantime?
In the meantime, you're going to do full-blown ACLS, whether it's volume resuscitation, vasopressors, inotropes, CPR. I think it's full court press with that situation.
So one educational point to keep in mind, this device is transvalvular. So if that doesn't start, you just have to take it out before start ACLS. That's a very important point, because first the aortic valve keeps open. So you will have AI, even if you're doing chest compression, whatever you try to bring it back, and you can cause damage also. So in those cases, always before start ACLS, you have to pull the device out of the ventricle.
Yeah, absolutely. Thank you for that point. One other thing I'll say real quick too about durable LVADs and codes, a Lucas device, lots of controversy there. Again, know your facility. Most of us are going to say, please no, don't do that. But there's a few places here and there. And that's a key thing to teach your EMS teams too, when you send these patients out into the community, how to manage those patients. So again, being proactive.
One quick comment by Arvin, 1 minute.
Yeah, I think I was just going to add a couple comments that we need to do better at figuring out an ACLS in this space, because the world has changed, but ACLS certifications have not changed. And it's specific to a few areas. I think in VADs, there needs to be a little bit of a standardization in codes. One other aspect I would add to the ACLS that we published a case report, and in some patients who have primary RV failure and you know the pump is working okay, I know there's a modified CPR that you do. I called it RV CPR because you don't need to compress entirely to compress the left ventricle. So some of these things are kind of controversial, but I do think as a field we need to get together and standardize some of these things.
Yeah.
Thank you.
Thank you very much.
Thank you.